Yes. Good afternoon, everyone. Today we are going to briefly discuss about the hyponatremia. Routinely we will be seeing in the ER, okay, and we will briefly go through the mechanisms and how to evaluate the patients and the clinical symptoms, investigation, and how to correct the patient. Okay. Ultimately, last the gist I will tell you, because we, for analysis wise, for identification, we should evaluate a lot, but ultimately treatment will be controlling the or increasing, normalizing the electrolytes to prevent the side effects of severe hyponatremia. What is hyponatremia? The hyponatremia is the levels of sodium will be less than 135 millimoles per liter. It's a very common disorder. We will be seeing encountered in the emergency medicine. Around 22% of the hospitalized patients will be having hyponatremia, and it can occur either due to increased vasopressin, arginine vasopressin levels, or increased sensitivity to arginine vasopressin, and also low solute intake. You can have these both these components along with and also in correlation with the patient fluid volume. Coming to the hyponatremia, three components we should see. You will be having the patient with hyponatremia in the settings of hypovolemia or euvolemia or hypervolemia. In case of hypovolemic hyponatremia, it routinely the total body water will be reduced along with the sodium levels. The common finding causes are gastrointestinal. It can be due to vomiting or diarrhea. In this case, if you see, the urinary sodium will be less than 20 milliequivalents per liter. And in case of insensible losses like sweating and burns also, you will be having this. And in the absence of adequate fluid replacement and along with the sodium, urinary sodium less than 20 milliequivalents will be seen. In case of renal causes, the sodium excretion will be more than 20 milliequivalents in the urine. And cerebral salt wasting syndrome, there are a lot of things which will come under this one, like hemorrhages, masses, meningeal infections like encephalitis, meningitis, brain trauma, and other things will be coming in the SIDH. Okay, we will go in the detail in that slide. And also diuretic use. In the starting point of initiation of thiazide diuretics or excess usage of diuretics also will produce the symptoms of the patient may land in hyponatremia. But thiazide diuretics are more prone when compared to loop diuretics. Okay. And aldosterone deficiency, Addison's disease. Okay. It acts on the distal convoluted tubule and the aldosterone receptors, ENaC cells, and it reduces the sodium concentration. Okay. It also produces the hyponatremia. Coming to the ADH receptors and actions. Routinely two receptors, and A1 is subdivided into A1 V1A and V1B. In V1A, it mainly presents on the vascular smooth muscle that leads to the vasoconstriction of the smooth muscle that increases the systemic vascular resistance and also the afterload. If it acts on the platelets, that leading to the platelet aggregation, it acts on the hepatocytes and produces the glycogenolysis. Coming to the V2 receptor, it's mainly it is present on the distal convoluted tubule and also the collecting duct and the collecting tubule. This receptor will be present on the basolateral area, the luminal side, okay, and it is also present on the vascular endothelium. A V2 receptor acting, it will maintain the absorption of free water from the tubule, okay, and the other one, it acts on the vascular endothelium for the release of van Willebrand factor. Coming to the V3 receptor is nothing but V1B. It acts on the anterior pituitary gland for the secretion of ACTH, prolactin and endorphin release. In euvolemic hyponatremia, it occurs in the settings of increased total body water, and also the total sodium will be more, and if you see the urinary sodium levels will be more than 20 milliequivalents per liter. The routine causes will be, it can be SIDH or hypothyroidism or glucocorticoid deficiency or psychogenic polydipsia. It occurs, see, in moderate to severe hypothyroidism it can occur, in glucocorticoid deficiency which exerts the negative feedback for the AVP release. That's why if you give the hydrocortisone replacement, it will normalize the AVP levels and responds to the osmolality, okay, and it reduces the circulating AVP. SIDH, the most frequent cause for euvolemic hyponatremia, and there are 4 different patterns of AVPs. One, there is no rational unregulated or erratic production of AVP without collaborating with the serum osmolality. Actually, if the serum osmolality increases, there should be a response and the AVP should increase. But here in these patients, it occurs about 1/3 of the patients. There is no relation between the AVP release and the serum osmolality. The other one, second one, you will be having the suppressed or failure of AVP suppression, and renin arginine vasopressin levels are not suppressed at low serum osmolality level, and it will be still stimulated. Okay, that's why it leads to hyponatremia. But in this patient, that there will be normal response to hyperosmolality, but as the osmolality comes down, there should be suppression. That suppression won't be there. The third one is reset of osmostat. Nothing but even at the low osmolality, routinely around 280 or 285, there should be stimulation to the your pituitary gland for the secretion of this AVP. Okay, even that set point will be less. Even below the 280 levels, there will be stimulation and excess production of AVP that is leading to the retention of water. Okay, the other one is gain of function of V2 receptors. Arginine vasopressin receptor gain of function will be there, and that is leading to excess absorption of water from the collecting tubules and the collecting duct. Routinely, the uric acid levels will be often low in SIDH. Okay, as there is a dilution, the uric acid levels will be routinely less. You will go to the next slide where you will see the detailed picture of the causes of SIDH. See, here it can be malignant causes, the carcinomas of lung. The routine carcinomas of the lung can be small cell carcinoma or mesotheliomas. Coming to the oropharyngeal cancers and the gastrointestinal cancers can be from the stomach, duodenum or pancreas. Coming to the genitourinary tract, there can be malignancies from the ureter, bladder, prostate and endometrium, and endocrine, there can be thymomas, and other malignancies can be from the lymphoma and sarcoma, mostly Ewing sarcoma will also stimulate. Coming to the pulmonary conditions, infections like pneumonia, bacterial pneumonia, viral pneumonias, along with pulmonary abscess, tuberculosis, aspergillosis, asthma, and cystic fibrosis. And the other one is, if the patient is on positive pressure ventilation, respiratory failure associated with the positive pressure breathing also, it induces the SIDH. Coming to the central nervous system causes, it can be due to the infections like encephalitis, meningitis, brain abscess, and rickettsial disease like Rocky Mountain spotted fever or acquired immunodeficiency disorder, AIDS. Or coming to the bleeding and masses, the patient may have subdural hematoma or subarachnoid hemorrhage, and also the other tumors can be there, brain tumors, cerebrovascular accident, hydrocephalus, and also the cavernous sinus thrombosis. Other demyelinating diseases like multiple sclerosis, Guillain-Barré syndrome, Scheidegger syndrome, and also the delirium tremors and acute intermittent porphyria can also stimulate SADH. Coming to the drugs, either these drugs will increase the AVP release, or also these may stimulate or enhance the action of arginine vasopressin. The most commonly these encountered drugs are chlorpropamide, selective serotonin reuptake inhibitors, tricyclic antidepressants, clofebrate, and anticonvulsant like carbamazepine, and anti-cancer drug like vincristine, ifosfamide, cyclophosphamide, and stimulant drugs like nicotine, narcotics, MDMA like ecstasy, molly. Okay, this MDMA and ecstasy, these will be act on the thirst center, and also increases the thirst of the patient, and also the intake of water. Okay, and other is AVP analogs, desmopressin, oxytocin, and vasopressin. Coming to the other causes will be gain of function of V2 receptors. Others can be less common causes can be either idiopathic or transient or exercise endurance. And coming to the general anesthesia also, it can be due to general anesthesia, nausea, pain, any stress can also induce the SADH production. Coming to the clinical features, hyponatremia induces the generalized swelling, cellular swelling, and that leads mainly is due to osmotic gradient of the fluid from the extracellular space into the intracellular compartment, as there is osmolality is more inside the cell. The symptoms develop due to cerebral edema, as a skull is a fixed space. If there is any swelling of the brain, that leads to these side effects. The CNS response is increase in the interstitial pressure, causing the shunting of the fluid from the ECF into cerebrospinal fluid, then into the systemic circulation. This is accompanied by efflux of sodium, potassium, and also the chloride from the brain cells. In acute hyponatremic encephalopathy, to ensure our body try to compensate, and the regulatory if it is beyond the capacity of the regulatory mechanisms, then the patient develops the symptoms of acute hyponatremia. Okay. Clinical symptoms. Early symptoms can be nausea, vomiting, headache. In severe symptoms, the patient can is prone for the seizures. There can be herniation of the brainstem herniation can be there. They can land in coma or death. Hyponatremia is also, this is one of the things, hyponatremia is associated with normocapnic or hypercapnic respiratory failure. This is due to non-cardiogenic or neurogenic pulmonary edema. Neurogenic pulmonary edema, in which the pulmonary capillary wedge pressure will be normal. Okay? Because what will happen is the root cause for the neurogenic pulmonary edema is there will be the centers in the brain like rostral ventrolateral part of medulla along the area postrema, and solitary nucleus, dorsal ventral, dorsal ventral, dorsal vagal nucleus, dorsal motor vagus nucleus. These are the centers which will induce the neurogenic pulmonary edema. If there is changes in the electrolytes, these will be sensed by these areas which are called the trigger zones of the brain. That leads to increased sympathetic outflow, that increases the systemic vascular resistance, and that leads to vasodilatation of the pulmonary vessels, leading to the alveolar edema and also the interstitial edema. Along with a reduced parasympathetic outflow, it can also produce the bradycardia. That is the main mechanism what is the that will be going on in the neurogenic pulmonary edema. These are the iatrogenic causes or acute causes of hyponatremia, where you will be having post-operative menopausal, premenopausal women, and using the hypotonic fluids in case of raised vasopressin. Already there is elevated levels of vasopressin. If you are further giving the hypotonic solutions, it will exaggerate. And the surgical procedures like TURP, transurethral resection of prostate, and also the uterine surgeries where you will be using the glycine irrigation, and also the colonoscopic preparation also will produce hyponatremia. The recent, early or starting point of institution of thiazide diuretics also can produce the acute hyponatremia along with polydipsia, along with these stimulant drugs and also exercise, and it can be due to both the polydipsia and also thiazide drug intake. Chronic hyponatremia. The time period is 48 hours. Beyond any symptoms beyond the 48 hours will be considered as the chronic hyponatremia. Symptoms, but clear cutly we can't differentiate, okay, to some extent, okay, whether it is acute or chronic, but if it is prolonged beyond 48 hours, you will be considering it as hyponatremia, chronic hyponatremia. The time period is clinically defined as chronic hyponatremia is 48 hours. The temporal definition is considerable relevance to the treatment of hyponatremia. Okay. Hyponatremia, what will happen is the organic osmolytes that are present in the neuronal cells like creatine, betaine, taurine, and you will also have the glutamate, inositol will be there in the neurons. These osmolytes within the neuronal cells will be a flux, so that to increase the osmolality of the CSF fluid, to prevent the migration of fluid from the CSF into the neuron, and to reduce the cerebral edema. If it is beyond this capacity, then only the patient will develop the symptoms. Then coming to the symptoms, the patient's sodium levels less than 125 milliequivalents per liter, then that's the critical level. The patient may have subtle, just the gait abnormalities can be there, okay, gait disturbances and cognitive defects which are reversible, and increased bony fractures, either it can be due to neurological dysfunction and the loss of the balance, and also it also affects the bone density. That's why even in the asymptomatic hyponatremia, early correction should be required. Therefore, every attempt should be made to correct the sodium levels in apparently asymptomatic individuals also. Okay. Risks associated with the correction. Normally, rapid correction should not be done. Only 10 to, though you calculate the difference is very high, you should correct the sodium levels in the first 24 hours, maximum 10 to 12 millimoles per liter. And in the second day, within 48 hours, maximum 18 millimoles within the 48 hours. Why? Because if you are correcting beyond that, that can lead to disruption of the blood-brain barrier, and you will be stimulating the immune mediator causing the demyelination. It's called the serious condition which causes the central pontine myelinolysis. The structures which are involved in the osmotic demyelination syndrome primarily is pons. The other regions can also be included are cerebellum, lateral geniculate body, thalamus, putamen, cerebral cortex, and subcortical regions in the decreasing frequency. Mostly is pons. Coming to the clinical symptoms of osmotic demyelination, okay, clinically it will present after 1 to 3 days of the correction of sodium levels. They can have paraparesis, quadriparesis, dysphagia, diplopia, dysarthria, and sometimes in severe cases the patient can land in locked-in syndrome and or loss of consciousness. If the other parts of the brain other than the pons are affected, the respective symptoms will be there, where they will be having ataxia, Parkinsonism, mutism, dystonia, and catatonia. And ODS development is accentuated in patients with malnourishment, alcoholic people, alcoholism, hypokalemia, malnourishment, and CLD diseases, chronic liver diseases. The ODS chances are very high. That's why the correction should be slow and gradual. Okay. Diagnostic evaluation, we should take the detailed history of the drug history, volume status, and you should evaluate for the elevated levels of arginine vasopressin, imaging for the pulmonary and the CNS, and laboratory investigation, you should measure the serum osmolality to rule out the pseudo hyponatremia, and also the RFT levels to involvement of the any kidney function, and hyperkalemia to rule out any adrenal insufficiency or hypoaldosteronism, and sugar levels. In case of severe uncontrolled sugars also, for every raise of 100 milligrams of deciliter, there can be change of sodium concentration 1.6 to 2.4 millimoles for every 100 milligrams per deciliter increase in the glucose levels. Okay, and you should also check for the uric acid levels. Routinely it will be less. If the uric acid levels is less than 4 milligrams, it is suggestive of SIDH, and if it is hyperuricemia, the patient will be in the hypervolemic state, not the hypovolemic state. Here this is hyperuricemia is volume depletion, nothing but if the concentration of uric acid is less, that implies the volume status of the patient is normal or high. If it is concentrated, that's volume status is depleted. And synchrotron test, cosintropin test, this is to identify the primary adrenal insufficiency, and also the thyroid function test to identify whether the patient is under moderate or severe hypothyroidism, which can lead to hyponatremia. Urinary solutes, this is also very important because it's crucial to identify, because the urinary sodium levels between 20 to 30 millimoles are suggestive of hypovolemic hyponatremia, in contrast to sodium levels more than 30 millimoles, okay, in SIDH. The gold standard is for hypovolemic hyponatremia, after giving the normal saline, the hyponatremia will correct rapidly. Coming to the urinary osmolality, if the urinary osmolality is less than 100 milliosmoles per kg, it is psychogenic polydipsia. If it is more than 400 milliosmoles per kg, it is due to excessive production of AVP. Between 100 to 400, it will be having the multifactorial. We should evaluate. Here the classification of hyponatremia, the mild is from 135 to 129, moderate is 125 to 129, and profound is less than 125. The absolute sodium concentration and the symptoms may not correlate with the degree of hyponatremia. It depends, vary from person to person. And you should identify whether it is acute or chronic, the time of development. This is also, the development is not always known because we can't clearly identify. Symptomatic or asymptomatic, presence of symptoms or any non-specific symptoms. Coming to whether it's a hypotonia, hypotonic fluid, or isotonic or hypertonic, the serum osmolality should be tested, and you will be also testing the non-effective osmols like urea and ethanol. Okay. And coming to the volume status, whether hypovolemia, euvolemia or hypervolemia, it should be depending on the, this is also you will be assessing, but the sensitivity and specificity of the test is less. Coming to the treatment, here the rapidity of dip of sodium levels is directly responsible for the severity of the symptoms. Consideration for the treatment is severity of the symptoms, first thing, either whether it is acute or chronic hyponatremia, and the next one is, then you should use, whether you should use arginine vasopressin antagonist or normal saline or hypertonic saline. In response to this, the response after using this Vaptans or normal saline or hypertonic saline is highly unpredictable. That's why you should test the sodium levels every 2 to 4 hours. Okay. In chronic hyponatremia, the cornerstone is you should stop the water intake by the patient, and for using that you will be using the ratio between the plasma, urine to plasma electrolyte ratio, urinary sodium and potassium divided by the plasma sodium. If this ratio is more than 1, then you should reduce the fluid intake by less than half liter. If this is almost equal to 1, then you can allow the patient to take 500 to 700 ml per day. If it is less than 1, then you should reduce the intake from 700 to 1 liter. Okay. Chronic hyponatremia. The correction is always you should correct 8 to 10 milli equivalents per day and 18 milli equivalents for 48 hours. Very low rate should be corrected in alcoholics and hypokalemia and malnourishment and CLD cases. Around 10% of the patient treated with Vaptans, there can be chances of overcorrection. And if the overcorrection of hyponatremia can again be safely, you can use desmopressin, arginine vasopressin agonist, okay, and free water like 5% dextrose to prevent or reverse the osmotic demyelination syndrome. Here what you will do is you will be giving the desmopressin acetate BD, along with that you can give the hypertonic saline, so that gradually you can improve and you can prevent the sudden correction, rapid correction of hyponatremia. Coming to the treatment of acute hyponatremia, the rapidity you can, in acute symptomatic hyponatremia, the correction should be 1 to 2 millimoles per hour. 1 to 2 millimoles per hour. But your target should be only 4 to 6 millimoles is sufficient to alleviate the symptoms. To reduce the symptoms, 4 to 6 mm will be sufficient. Later on you can shift to the correction of chronic hyponatremia. As you treat the chronic hyponatremia cases, okay, only from the starting increase of 4 to 6 millimoles or milliequivalents of sodium is sufficient to alleviate the symptoms of hyponatremia. Okay. How to calculate? Though you calculate this one, the sodium deficit is 0.6 into body weight into your target minus patient. But ultimately what you will do, maximum correction is 8 to 10 milliequivalents per day. Then you will be using approximately only 10. Here you can use around 8 or 9, and it will be approximate 400 or 450. If you take the weight of the person is around 70 kgs, it will come around 478, and you will be dividing into 24 hours, and it will be maximum 30 ml of 3% NaCl per hour you will be infusing. A reduced amount of infusion is far better. But in acute conditions, within 2 to 3 hours in the starting point you can give. Later on, once the target of increased sodium levels increase more than 4 to 6 mm, then you can reduce the rate. Okay. Let's see here the monitoring, sodium monitoring can be done between 2 to 4 hours. We mentioned 4 hours, but we can use 4 hours. Vaptans have no role in acute hyponatremia. There is no role of Vaptans because it takes time. Okay. Treatment of cause. In euvolemic hyponatremia, you should treat the cause: SIDH, SIADH, hypothyroidism, secondary adrenal failures. In case of hypovolemic hyponatremia, you can use the IV fluids, normal saline. In hypervolemic hyponatremia, you should treat the cause. it mostly it is caused by congestive heart failure, cirrhosis, nephrotic syndrome. If you treat the cause, then it will be normalized. Beer proteinuric, what they will be taking the beer will contain the less amount of solute and more water and also reduced amounts of nutrients. In these patients, you should give the saline and also the normal diet, but the correction should be slow because the patient will be in the malnourishment and also severe hypokalemia. They can land in ODS. Okay. Treatment of SADH, you combined therapy you will be using either furosemide 20 mg BD along with oral salt tablets you will be using, and if these fails you can use the demiclocycline and also oral urea if it is palatable for the patient. This demiclocycline will block the V2 receptors. It mainly blocks that acetylation, secondary messenger will be there within the distal convoluted tubule that will block that cyclic AMP levels and also the protein A levels, so that the V2 receptor won't be incorporated into the apical side of the tubule. Okay. Vaptans, the effect is it is effective in SIDH, hypervolemic hyponatremia, and it is not at all used in hypovolemia and also acute hyponatremia. Vaptan, tolvaptan can be used orally. Starting you will be using the minimal dose 15 mg. Later on you can go up to 30 to 60 mg you can use. And conivaptan is it has the combined effect V1 vasoconstriction and also the V2 receptor levels. It can cause the side effects of hypertension. And one more thing you should keep it in your mind is you can't place the vaptans beyond 1 or 2 months because the LFT will be deranged. Liver functions will be abnormal if you are continuously using the vaptans. See, this is a diagrammatic representation where you will be having the volume status of the individual. There is the table from the Harrison. You can see the hypovolemia where the total body water will be less and also the sodium will be further reduced. And once again it is divided into components where the urinary sodium is more in case of renal causes, either due to diuretic excess or mineralocorticoid deficiency or salt losing deficiencies that can be due to renal causes, and bicarbonaturia along with the renal tubular acidosis or metabolic alkalosis which is caused by, it can be due to vomiting, diarrhea also, and ketonuria, osmotic diuresis and cerebral salt wasting conditions. Coming to the extrarenal losses, here the urinary sodium concentration is less than 20. Here you will be having the extrarenal causes, vomiting, diarrhea, third space losses, burns, and also pancreatitis, trauma. These will be trauma leading to hemorrhage of the any intra-abdominal hemorrhage. These will be causing. Coming to the euvolemia, the total body water and the total sodium levels, total body water will be high, but the sodium levels will be normal. That can lead to hyponatremia. Here the urinary sodium will be more than 20. The routine common causes is glucocorticoid deficiency or hypothyroidism or stress, drugs or SIDH. Coming to the hypervolemia, here the water content is high, very high, and also the sodium levels are high. The most, once again you will be dividing into two. Here the sodium concentration, urinary sodium concentration more than 20 in case of renal failure, acute or chronic renal failure, and the urinary sodium concentration is less because as the blood pressure is less, that is sensed by the nephrons, it once again leads to increased production of arginine vasopressin. Okay. Here the treatment should be aimed on treatment the primary cause of cardiac failure, cirrhosis and nephrotic syndrome. Coming to the last slide. Okay. Here first you should identify whether the hyponatremia is severe or mild. If the hyponatremia is severe, that is less than 125 millimoles, then if it is yes, then you should go. If the patient is having any symptoms of hyponatremia, either seizures, vomiting, obtundation, coma, or respiratory distress, or any gait abnormalities or falls, if it is yes, then you should identify the duration. If it is less than 48 hours, it is acute hyponatremia, and if it is more than 48 hours, that is chronic hyponatremia. In acute hyponatremia, you can increase the sodium levels up to 4 to 6 millimoles correction. That will alleviate the symptoms. Later on, you can change to total correction to 8 millimoles per day. And coming to the chronic, you will be, that means if you use the 3% NaCl, 1 ml per kg per hour, it will correct the sodium levels to 1 milliequivalent. Okay, if the person is around 60 kgs or 70 kgs, 1 ml per kg of 1 ml, that is 60 ml. If the weight is 60 ml of 3% NaCl will increase the sodium levels to 1 milliequivalent per hour. Okay, and coming to in the chronic, you will be using only 0.5 to 1 ml per kg per hour, that is approximately around 30 ml. And you can also use, here there is no role of, in acute hyponatremia there is no role of vaptains. In chronic, you can use the 12-vaptan, and the starting dose can be 15, then later on you will be increasing. Okay, and there are no significant symptoms. If the patient is having slight irritability, headache, difficulty in concentration, altered mood and depression, here you should try to restrict the fluid intake. Ranging from half liter to 1 liter. You will see that the ratio between the sodium electrolyte concentration, sodium, urinary sodium and potassium to sodium levels. And if it is more than 1, then you will be reducing the sodium levels to less than 1. If it is almost equal, 500 to 700 ml. If it is further less, then 700 to 1 liter you can use. Okay. Ultimately, the last one is here, because the normal saline, the millimoles of sodium, milliequivalents of sodium is 154, and 0.9% is 154. 3% will be around 515. Based on that, the deficit you will be calculating, and you will be slowly correcting. Okay. But one thing you should remember in mind is, though the deficit is very high, you can't transfuse rapidly. In case of alcoholics, the correction should be much less than the routine. Only the correction within 1 day target should be 8 or less. In alcoholics, it should be around 6. That will be comparatively safe. Okay.
Then how will you plan for replacement volume with normal saline? The 0.9% normal saline. How much volume? That is 280 by 154. The chloride deficit is 280. 280 by sodium present in the IV fluids. We are giving normal saline. So it is 154. Means we have to give 1.8, around 1.8 liters of normal saline. Ideally, we will give 100 ml per hour. Ideally, we will give 100 ml per hour. So we will adjust this to 18 hours. We will give 100 ml per hour for 18 hours. So even in a simple case like vomiting There are four or five vomitings, even it is a simple case, even if we plan for normal saline, we should know whether there is metabolic alkalosis or not. We look for metabolic alkalosis. Then second step is, we should know the chloride deficit. We should know whether the patient is chloride responsive or chloride non-responsive. For that we have to check urine chloride level. If urine chloride is less than 15, it means it is responsive. If urine chloride is more than 20, means it is non-responsive, it is a refractory case. If patient may develop hyponatremia, hypokalemia. If there is hypokalemia, if you don't correct hypokalemia, patient may develop cardiac arrhythmias and cardiac arrest. The further, an important mechanism in distal tubule is, do you know about pendrin? Pendrin pathway. Pendrin pathway is chloride bicarbonate pathway. Distal tubular cell is human. The pendrin pathway is absorption of chloride and secretion of bicarbonate. Secretion of bicarbonate and absorption of chloride. If there is hypokalemia, this absorption of chloride is affected. Patient has hypokalemia, this pendrin pathway is affected. Absorption of chloride will be affected. So we have to check potassium levels. First we have to correct potassium also. We should correct potassium, then we should give normal saline. Without correcting potassium, patient may not be responsible to chloride. So even in a simple case of vomitings, we plan for normal saline. We should know whether metabolic alkalosis is present or not. We should know whether the patient is chloride responsive or not. We should check other electrolytes. We should know the replacement volume and infusion rate properly. That's one important point. So regarding the fluid management and electrolyte balance, even in a case of hyponatremia, we should know total body water. How do you assess total body water? The current total body water. Patient presents with hyponatremia, sodium 130. How do you know current body water? Sodium change means body water change. Sodium change means total body water change. The equation is current total body water into current plasma sodium is equal to normal total body water into normal plasma sodium. Normal sodium is 140. Okay? Normal sodium is 140. The normal total body water is 70 kg adult. 70 kg adult woman, 50% is total body water. 70 kg adult, 50% will be woman total body water. In 35. Okay. We know the current plasma sodium. In hyponatremia cases, suppose if plasma sodium is 160, we can get current body total body water. Total body water is equal to normal total body water, that is 35, normal plasma sodium, that is 140, divided by current plasma sodium, that is 160. That gives current total body water. So it will be around 30.5. Hmm, 30.5. So normal total body water is in a 70 kg adult in a woman is 35. So if sodium is 160, total body water will be 30.5. So we should know the current total body water. That is the first step. Then we should know free water deficit. How do you know free water deficit? Free water deficit is normal total body water minus current total body water. That is water deficit. Free water deficit is normal total body water, that is 35. Current patient's total body water, that is 30.5. It means free water deficit is 4.5. Then how do you plan for replacement volume? We want to give half normal saline, 0.45% normal saline. So how do you decide? If patient has 160 sodium, how do you decide? Replacement volume, replacement time, infusion rate. So we should know total body water, current total body water, free water deficit, replacement volume, replacement time, infusion rate, sodium deficit, and free water clearance.